Good day, my dear undergraduate and emerging postgraduate students. I welcome you to today's class on What Next with a clinical history. A middle-aged man came to the hospital with complaints of vague abdominal pain that has been persisting for weeks. On examination, the doctor found no mass palpable. On further questioning, the patient gives a history of traveling and that he is a salesperson by occupation. In spite of the first line of treatment, as the patient was not improving, an endoscopic biopsy was asked for, which showed this kind of a picture. I would like you to kindly have a look at it and then come to a diagnosis. I am pertinently giving this because there is a chance that we might get problem-based questions. So the diagnosis is Helicobacter gastritis. The subjects that are covered in this include these. And in this class, I have been concentrating on medicine and pathology. After all, it is medicine and allied that is the target right now, and these are the subjects included. Secondly, this is not for any 1 year of students, but for all MBBS students. I always discourage my students from approaching MCQs directly. On the contrary, from today's class, I would very much appreciate if you can frame your own multiple choice questions. Nevertheless, this class shall be dealing with the general features, etiology, organism, pathogenesis manifestation, lesions, diagnosis, and treatment. Think of the subheadings, it will take us to the answer. And this is a good diagram from probably the Gray's Anatomy where the rugosity of the stomach is well made out. I am able to see the fundus, the cardia, the greater curvature, the lesser curvature, and lower down there is the antrum and the pylorus and the first part of the duodenum. This much we shall have. No further accuracy is needed in anatomy. The causative organism is Helicobacter pylori. It belongs to the phylum Campylobacter. Earlier, Campylobacter and Helicobacter were presumed to be the same. But this is more specific. Helicobacter pylori. The organism is spiral or curvilinear. It causes duodenal ulcers, gastric ulcers, chronic gastritis, antral gastritis due to increased amount of acid production. And it is commonly limited to the antrum and probably the first part of the duodenum. Later on, it can cause a more generalized gastritis. So this much we shall be having in mind. It was found initially by Marshall and Warren in the year 1982. Later on, more contributions have been pouring in at that time. So this is the structure of the Helicobacter pylori. You find it is not straight, it is not curved, it is curvilinear. It has got flagella and then there is the various elements that are present on the surface or that it is secreting. We shall be seeing them. Even in countries like the United States, it was common due to poverty, crowding, migrated population, poor sanitation. If it is a childhood infection, it can persist for a long time. And in India, it is presumed that nearly 70 to 80% of the population has been inflicted with it. The routes of spread are oral or fecal-oral. The symptoms involved, usually a pain and a nausea. Later on, there might be hematemesis, melena, and at the fag end of it, this is not to be mentioned as a symptom, but then the patient can go in for something called as maltoma, which arises from the mucosa associated lymphoid tissue. That is why it is called maltoma, which is a B cell lymphoma. We shall be seeing it. So, when you people read, you should be able to distinguish between the irrelevant and the relevant. For example, hematemesis, melena, oral, fecal-oral. These might not be very good questions to be asked. Look at the picture on the pathogenesis. This is the normal type of epithelium. It is quite tall, and you find that there will be a string of mucus over here. Look at this. This gray zone is the mucus. Normally, it is the mucus that is protecting it. After all, our stomach itself is secreting powerful acids. And this is the organism we have been talking about. It gets adhered to the mucosa, and there is a secretion of the urease, which neutralizes the gastric acid, and you find that there is a damage that is caused to the lining epithelium. Later on, you find that there can be more of these organisms that come in, and there is a havoc at the gastric mucosa, which can lead to the mucosal damage as mentioned. There can also be inflammation. Though it is a chronic lesion, chronic means for months and years. Usually lymphocytes, plasma cells should be there. But here we get the neutrophil source. And finally, there can be a death of the mucosal cells by means of the cytotoxins and the ammonia. So this is one picture we can have in a corner of our mind for the pathogenesis. This is a much more pertinent picture from the multiple choice question part of it. So there are the flagella for the mobility and the motility. Urease for neutralizing the gastric acid. Lipopolysaccharides, which help in adhesions. And there are also outer proteins which help in addition to the host cells. Exotoxins, VACA, that is important. Vacuolating toxin, that is one. And there can be enzymes such as mucinase, proteinase, lipase, etc., leading to the digestion. These two factors people should be remembering. SAGA is one, cytotoxin associated G, and then VACA is vacuolating toxin. I would like you people to explain the adapted ecological niche over here. What is the favorable gastric mucus? Adhesion, urease, adhesins, and the toxins. These two are important, which may be in our MCQs. Also, you find that pili are different from the flagella in that they help in adhesion. Coming back to our diagram over here. So this is a gastric pit. There is a gastric pit, and I find, are you able to see some dark lines over here? The arrow also points out to it. So these organisms are there at the surface of the epithelium. They have not invaded inside. They are in the mucus overlying the epithelium and also within the gastric pit. This is also a surface. There can be an infiltration with lymphocytes. Later on, there can be attempted lymphoid follicle formation. Plasma cells can be there. Neutrophilic infiltration is present, and when we people see, we used to give a report of chronic active gastritis. It can either be present in the form of small microabscesses or it can invade the epithelial cell. Also, there can be other changes such as intestinal metaplasia. So this is a useful schematic diagram. There is an establishment of colonization. So you saw in our first picture. And you find that there can be a duodenal ulcer that is developing. And there is either a neutral or an increase in the gastric acid. Later on, there can be an atrophic gastritis. So there is an atrophic gastritis. This can be associated with intestinal metaplasia. On the contrary, I am seeing, duodenal ulcer, gastric ulcer, or gastric carcinoma. Sometimes a lymphoma. This is what we should have in mind. And it persists from childhood up to adulthood. Now there are different diagnostic methods for the H. pylori. This is from Davidson, your textbook of medicine. There are non-invasive and invasive techniques. Serology, there can be rapid kits and it can be done for a large population screening. The problem is it lacks specificity. Urea breath test, it is highly sensitive and specific. But sometimes you find that more qualified instruments such as a spectrophotometer might be required. Fecal antigen test, it is cheap, it is specific, it should be good, but then it is not acceptable by the society or the doctors. Then we go to the invasive test, histology. It is specific and it takes a few days, at least 2 days for it to be processed and diagnosed. Rapid urease test is cheap and quick, but it lacks that amount of sensitivity. And microbiology culture is supposed to be the gold standard. And also antibiotic sensitivity test can be performed by it. But it is a slow and a laborious process. So this is a biopsy that has been done. In the initial picture, I showed you the organism, which was not very clear. But now on the surface, I am finding this dark brownish black or black colored curvilinear organisms on the surface of the epithelial cells. This is done by means of a R.A.T.S starry silver stain. It can be a question for us. Other stains are GMSA. And this is an immunohistochemistry that has been done. Routinely, we are doing this R.A.T.S starry silver stain to diagnose Helicobacter gastritis. The treatment can be proton pump inhibitor, amoxicillin, clarithromycin, metronidazole, either individually or in combination. I would like you people to kindly refer to the books on pharmacology and medicine. The keywords, as I had been mentioning, what is the site? What is the stain that can be used? What is the pathogenesis? What are all the various adhesive and the dissolving factors? What are the lesions? What are the malignancies? So these can be incorporated. I would like you people to at least frame 10 multiple choice questions. These are my references. And look at this over here. The Helicobacter pylori, initially it is all there on the surface, but later on you find that with the lowering of the pH and there is a dissolution of the mucus, you find that it penetrates. The credit goes to Wikipedia for this wonderful diagram. See you in What Next?